happy to see him always in the meetings of WFNS. And today I am so happy to see him speaking about the neurotrauma in the undeveloped countries and the income countries because he's expert in that and he can teach us a lot. Please, Professor Tariq, come into the microphone and tell us interesting things.
Thank you very much, Ahmad. Good to see you. Thank you for the very nice introduction. Thank you to Najia. Thank to Fahd. Thank to the Moroccan Society of Neurosurgeons for inviting me to this very important webinar and this very important topic as far as I'm concerned regarding neurotrauma management guidelines for LMICs. If you look at it straight away, jumping into the statistics, that 74% of surgeries for TBI are needed in lower and middle income countries. So these are the surgeries required. These are not the surgeries being done. So there's a huge, requirement of that. And also, if you look at the spinal surgeries, 89% of surgeries for traumatic spine, again, occur in lower and middle income countries. So it's very important to look at it through a holistic approach. And the holistic approach is going from prevention to rehabilitation. The most important parts, which we always miss, of course, in between the pre-hospital care, emergency room care, ICU, theater, and ward care are important. So we need to look at all of them together. So I want to tell you about this survey of Asian Australasian Society of Neurosurgeons, which we did in 2016-17 with some hospitals from India, from Indonesia, and from my hospital, Northwest, in Peshawar. And we looked at talking about prevention to see the helmet and seatbelt use, and we found that only 7% of people on motorbike were using helmets. If you look at the seatbelt use, there was only 13% of people using seatbelts. And of course, we have this concept somehow that one helmet will protect everybody, and also that we want to get into the Guinness Book of Records to have as many people on a motorbike as possible. So we started this project of prevention is better than cure. And we did that by doing seminars and by doing poster exhibitions and by doing getting the Neurotrauma Committee of the WFNS connected with the Think First International Injury Prevention Program so that we could collaborate together and we could tell people about how to have awareness seminars for people. And the first joint seminar was in 2019, ICRAN in Peshawar. I must also tell you that some of our colleges have that in their bachelor's programs where they can go and teach young students and explain to them about the prevention, which is very important. Then we looked at who provided emergency treatment at the site of the accident. And we found at the scene, and we found that majority were the lay people. There was no paramedics coming there to provide emergency treatment as in high-income countries. And then we looked at, did a nurse or doctor accompany the patient in the ambulance or in the vehicle to the hospital? And again, we found that in the majority of cases, there was no nurse, doctor, paramedic accompanying the patient to the hospital. So we know it's very important that in the phase of injury, 50% who die from TBI do so within 2 hours of injury, and 40% of pre-hospital deaths are potentially preventable. And if you look at these statistics, 59% of trauma deaths occurred in the field in high-income countries, compared to 72% in middle-income, low-income countries. And in Kenya, for example, only 52% of patients arrived at the hospital within 30 minutes after a road traffic injury, and only 72% within 1 hour. So, and then when we looked at the duration to surgery, we found that there was a big gap from the time of the accident coming to the surgery. So we know that the management is geared towards the prevention of secondary injuries and rehabilitation. Secondary injuries like hypoxia, hypotension, edema, raised ICP lead to increased mortality and morbidity. And longer the delay, the greater the mortality and morbidity. So the most important thing is to have trained paramedics, good ambulance service, to be able to be at the site as quickly as possible and transfer the patients quickly, but more importantly, safely to the hospital. The in-hospital management is guided by GCS monitoring, CT scan, ICP monitoring, pupillary response. The goal is supportive treatment and prevention of secondary damage. The Brain Trauma Foundation guidelines are evidence-based, and there's the general maneuvers with head elevation, normothermia, sedation, volume resuscitation. And then the first line of therapy is CSF drainage, hypocapnia, mannitol or 3% saline. And then the second tier is high-dose barbiturates, intense hypoventilation, raising the mean arterial pressure, mild to moderate hypothermia, and then more importantly, decompressive chronectomies. And there's level 2A evidence that bifrontal decompressive chronectomy has been shown to reduce ICP and stay in intensive care, but not the Glasgow outcome at 6 months. And important that a large frontotemporoparietal decompressive chronectomy, at least 12 by 15 centimeter, or reduce mortality and improve neurological outcome. Very important if you're doing a decompressive chronectomy, it must be large, must be big. Then level 2B evidence that data from ICP monitoring reduces hospital stay and 2 weeks post-injury mortality. And ICP should be monitored in all salvageable patients with GCS 3 to 8 after resuscitation with CT changes. ICP monitoring is indicated in severe TBI with normal CT, but having 2 or more features of admission, age greater than 40, unilateral bilateral motor posturing, or systolic blood pressure less than 90. But the guidelines for lower and middle income countries, majority of the severe traumatic brain injury patients globally are managed without ICP monitoring, even in high income countries. There's no recent literature to guide management in non-monitored patients. We know that large part of literature comes from well-equipped larger centers in high-income countries. There are no resource-based guidelines in LMICs to guide surgical TBI management. The Neurotrauma Committee of WFN has formed a small committee headed by Andres Rubiano from Colombia to develop stratified guidelines. And this is a very interesting paper which you must read. It's a recommendation of the Colombian Consensus Committee for Management of Traumatic Brain Injuries in pre-hospital, emergency department surgery, and intensive care. It's called Beyond One Option for Treatment of Traumatic Brain Injury, a stratified protocol called Bootstrap. And of course, there have to be guidelines and assessments. And we wrote this commentary on that paper with a paradigm shift from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle-income countries. So the importance was that they cannot be protocols by guidelines, but they have to be done according to the resources available in each country. You may have read this important paper, the Best Trip Trial, which was the only tested non-ICP monitored treatment protocol, Chestnut and all. There was a lot of critique about it, and it found no evidence of outcome difference for monitored and non-monitored patients. And this trial compared ICP monitored patients versus non-monitored, that is imaging and clinical examination, which is called the ICE protocol. And this was the paper written, consensus-based management protocol, revised protocol, for the treatment of severe traumatic brain injuries, based on imaging and clinical examination, where ICP monitoring is not employed. And this is important because in lower and middle income countries, majority of these centers do not have ICP monitoring. So this is not a substitute, but a supplement for empirical evidence. It's an effort to provide for the vacuum left by absence of evidence-based guidelines, and it was many people were involved in developing this protocol. How are we doing it? We do a decompressive chronectomy on our admission, depending on the patient's condition. We may do ICP monitoring through intraventricular catheter, or then we use the Crevice protocol. And the indications for decompressive cranectomy straight away in trauma in our settings is if the CT scan findings show diffuse brain edema with or without brain contusions and subdural hematoma, if there is effacement of basal cisterns and ventricles, GCS is 9 to 12 or drop of 2 degrees from previous. If age is less than 70, because over 70 there is a 75% mortality. And if we are doing ICP monitoring, refractory ICP. The Crevice protocol suggests looking at the Marshall score on CT brain, interval CT scans, clinical score, GCS, neuroworsening, and pupillary response. So it's a 4-tiered management. I think most of the young neurosurgeons know about the Marshall grading. It depends on the cisterns, the midline shift, and mass lesion. And the intracranial hypertension is suspected and treatment is recommended in the presence of 1 major or 2 minor. And the major are compressed cisterns, midline shift, non-equated mass lesion. The minor are GCS motor score of 4 or less, pupillary asymmetry, abnormal pupillary activity, and CT classification of Marshall. So this is the neuroworsening. If there's a decrease in the motor score, if there's new loss of pupillary activity, if there's interval development of pupil asymmetry, new focal deficit, or herniation syndrome. And the imaging you do, according to the Crevice protocol, is initial, repeat to 12 hours, 24 hours, 48 hours, and then as required. So in tier 1, there's hypertonic saline, mannitol, maintain normothermia. In tier 2 is hypoventilation, again hypertonic saline by continuous infusion and increase in sedation. And then tier 3 is most important, decompressive cranectomy. Tier 4 is these untested protocols, nimodipine, hypothermia, magnesium, etc. And you escalate the therapy if there's neuro worsening, if there's no improvement or worsening on follow-up imaging, or no acceptable response to initial therapy. This is just the matrix. So this is important, that when can you wean the patient off the ventilator? And you can see that in the first 24 hours is very difficult. Then it becomes a bit easier. And it depends on the pupillary response, the Glasgow Coma scale, etc. And I would recommend that we do a study regarding this protocol. I think it's very important, very helpful for the lower and middle income countries. There was in 2017, we did a consensus meeting for decompressive cranectomies, and a statement came from that. I think you must read that. This is very important. It shows how and when one should do a decompressive cranectomy. Rehabilitation is one of the most important parts which is often neglected because of poor resources. It's multidisciplinary, and the role of family members is very important. Maybe we can train the family members to treat them. If you look at this study which we did, we found that the majority of the patients were being sent home. So if you train the family members, I think it will be very helpful to do that. And you may know, some of you may know about the Peshawar Recommendations. These were the comprehensive policy recommendations for head and spine injury care in LMICs. And these were done by the Harvard group, by Key Park, and by Northwest School of Medicine. They were launched last year in Peshawar during the ICRAN. And you also know that the Global Neurosurgery Committee was started. And the idea was, in addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And this was to develop special things for 2030, universal health coverage for everybody. And the idea is to get as many neurosurgeons in lower and middle income countries. And this is a timeline for it. Of course, it's a very tall order, but we are trying our best to achieve that. And the idea is to achieve universal access to neurosurgical care, to align and coordinate all global neurosurgery activities, to stimulate and facilitate relevant research, to engage with surgical stakeholders for building integrated surgical systems, to co-educate for investing in surgical care for all within universal health coverage. And some of the countries in Africa and some in Asia have started their national surgical programs for getting national surgical obstetric and anesthetic plan. And what we did was that we added the comprehensive guidelines for brain and spine injuries onto the national surgical obstetric program of Pakistan, and we hope the rest of the countries in LMICs can do that also. This was Neurosurgical Committee, which was launched last year in Peshawar. And the idea is to either train more neurosurgeons, and the Global Neurosurgery Committee is doing a lot for that, or to try and get non-neurosurgeons through support by the local neurosurgeon, by training, by teleradiology, by developing guidelines to do that. Thank you very much. Thank you for giving me time.
Thank you, Professor Tariq. Interesting lecture. I hope we can arrive to have global neurosurgery with the same guidelines in every place, because I feel that in Palestine mostly and in other Arab countries, some people are working in some way and the other in another way. Many times you feel that the decompressive craniectomy is very dangerous thing for the patient because they do it small or something that can close the wedging vein and making more edema in the brain. It is one of the most important procedures, I think, in neurosurgery, to have the chance to learn how to make a good decompressive craniectomy, really, and how to preserve the bone, and how to replace the bone, and when to do it, and when to replace the bone. Really, it is important to arrive to conclusions, which kind of preservation will be better for the bone, which kind of when the timing of the cranioplasty after that, and the timing of the decompressive craniectomy. Also, it is interesting, early better or to wait, at which intracranial pressure better. Really, since the first time that I'm here, since 8 years that I am back from Italy to Palestine, I didn't use the intracerebral monitoring, but I saved the life of many people using the compressive craniectomy. Just looking to the CT scan and the clinical data, if he is worsening 2 or 3 Glasgow scale low, and the effacement of the sulci and the basal cisterns were the guiding signs for me to do it. Thank you very much, Professor Tariq. And if anybody need to ask questions, he is welcome.
May I have a comment, Ahmed?
Yes.
Just to congratulate Professor Tariq Khan for this excellent talk and emphasizing the importance of the global neurosurgery today, and WHO today take this field, this topic, as one of the priorities in LMIC, low and middle income countries, because since 2, I think 3 or 4 years, I'm talking under the control of Professor Tariq Khan, because he was one of the pioneers of the global neurosurgery. And actually, currently, the brain trauma was of the priority of the WHO as not only for infection disease, for example, in some low and middle income countries. And as you said, and you highlight some, of course, how to fight against the brain trauma is the prevention. And the prevention, of course, of this brain trauma was have many, of course, many things to fight against it. Not only advancement campaign of advancements around the world for the road accident, for the accident of the falling, etc. So thank you for all this information, very interesting about the statistic in the world, and especially this great job that you are doing in Pakistan. And I know that it's one of the country that doing a lot in this field. Thank you, Tarek.
Thank you so much.
Thank you, Najia. Let us move back to Fahad to introduce the next speaker.
Before moving to the next speaker, there is Professor Khamlishi who is asking if maybe question.
There is
Good evening,
questions.
Professor Khamlishi.
Thank you, Fad. Thank you, Dr. Imad. Just, you hear me?
Yes.
Yeah, just to apologize first for arriving late, and I didn't get the chance to hear all the lecture of Professor Tariq Khan. But I would like, of course, to thank him and to tell him how we are happy to listen to his conference, and of course to welcome all the colleagues who are here. So sorry for arriving late.
Thank you.
Thank you, Professor Khamlishi, and thank you, Professor Khan, for this great talk, and we really appreciate your talk every time we attend them. So the second, we move to the second speaker, Professor Samuela Sanosi, and Professor Samuela Sanosi is well-known professor of neurosurgery in Africa and worldwide, and I will ask Professor Brahim Al-Mustarshid, the head of the department of the military hospital of Rabat, to introduce him.
So you can go on.
Okay.
Can go on. Yeah.
Okay. So Professor Sanosi is the president of the Nigerian Society of Neurosurgery, Société Nigérienne de Neurochirurgie, and he's president of the Association of Neurosurgical Societies of Africa, and he is the vice president of the CANS, and of course he is a well-known neurosurgeon and professor of neurosurgery, and let me say a needle for many young neurosurgeons. I am one of them, and we really appreciate his participation with us to the webinar. He was with us during the last week for the for the WFNS Rabat Reference Center course for African neurosurgeon, with a great talk of hydrocephalus, and today he will give us a talk about in neurotrauma topic. Welcome, Professor Sanosi, and please share your slides and share your science. Thank you.
Thank you very much. I hope that I'm understood.
Yes. Just
yes.
Your slide and full. Yes. Yeah. Excellent.
Yes.
Excellent.
Thank you.
So, thank you very much for inviting me.
We don't see you. Where is Professor Samuel?
We see him. We see him. Instead. Just
okay.
To put in.
It's okay.
Right, yeah.
Okay, do you see me, Professor Hamlishi, now?
Not yet.
I'm happy to see you again. Happy to be one of this webinar. Happy to see my sister Najia and my friend Fahad, and all Moroccan neurosurgeons. I'm very happy to be with you again. I understood that my presentation was for residents. So I focus it on how to fix some informations for management of brain contusion. So brain contusion is an evolutive and superficial cortical with vascular and cellular components associated with breaking up of hematoencephalic barrier. And brain attrition is an evolution of contusion interesting the cortex and the white matter. And brain hematoma is a collection of attrition. So contusions, attritions, and hematomas are vascular, cellular, and hematoencephalic barrier post-traumatic lesions. The interest of this question is for residents, and also for it's like an appeal to collaborative management. As we know, in our countries, we have intensification of traffic and also transgression of legislation about using of safety helmets. And the management of brain contusion have to consider first the knowledge of mechanism of secondary lesions. So as neurosurgeon, we have to change our mind. We have to make our reflection on how how is the evolution from primary lesion to secondary lesion. We have to think as a physiologist before thinking as a neurosurgeon for management of brain contusion. We know that the intensification of traffic, the cause was public road accident, falls, and last years, even in peaceful countries, we have ballistic trauma. So what is the mechanism? We know that we can have direct impact or indirect impact. During the direct impact, when the head is in movement, the brain is the trauma to brain is deceleration trauma. When the head is immobile, we have on the brain acceleration lesions cellular. And during the indirect impact, we have both acceleration and deceleration lesions. The impact can be absorbed. When the impact is absorbed, we can have fracture, extradural hematoma, subdural acute hematoma. When the impact is not absorbed, that is when we have contusions, attritions to really hematoma. And when we have spread of the shock wave, we have diffuse axonal lesions. Direct impact, it's the contact of brain against the bones reliefs. And for example, here, I try to make images aftermath lesions, and we can have lesion contralaterally. The spread of the shock wave can predict inside midbrain lesions, and for the contusion, at the beginning, it's a little lesion, but it's an evolutive lesion. And so we can move from contusion to attrition and hematoma. What is the support of this evolution from contusion to attrition and hematoma? When we have direct or an indirect impact, that's induce cellular lesions, glial or neuronal lesions, vascular lesions, and hematoencephalic barrier lesions. What is what we have when we have hematoencephalic barrier lesions? It induces vasogenic edema. During this vasogenic edema, we have passage of macromolecules, protein, and water to the extracellular space. During lesion on glial or neuronal lesions, the direct impact or the indirect impact induce cytotoxic edema. That is the basis of contusion, and it's the basis of the evolution from contusion to attrition and edema. The problem is after the direct or indirect lesion, we can have apoptosis or acute energetic deficit in the cellular. Apoptosis is like a genetic signal that the cellular will organize its self-destruction. The acute energetic deficit is the consequence of the blockage of Krebs 6 cycle that is induced by hypoxemia, which block the Krebs 6 and non-production of energy. That is induced to acidosis. Neural and glial cellular lesions, when you have neural lesions, it's induced release of potassium and magnesium, penetration of cytotoxic amino acid like glutamate and aspartate. We know that the level are high at G3 and G8. And the penetration into the cellular of the glutamate induce the activation of phospholipases, and the phospholipases induce the destruction of cellular membrane, ion channels, and membrane receivers. That is product free radicals. These free radicals are cytotoxic to normal cell. That is induce the vicious circle. These vicious circles associated with bleeding consequence increase the neurotoxicity. That is called in French axos, primitive neuroglial, vascular, and hematoencephalic barrier lesions conducted to self-governing cytotoxic secondary disturbance. Neurosurgeons have to know it, because without knowing it, it's not possible to decide where, how to, when to manage, and which kind of management we can done for the patient. So, vasogenic, cytotoxic edema, and secondary autonomous disturbance induce and progressive increasing of intracranial pressure. The contusion is an evolutive lesions from contusion to autonomous metabolic disturbance and increasing of intracranial pressure. So for management of contusion, we must include this physiopathology first before surgery. What is the global management in the intensive room care? What is important is the recording, the monitoring of ICP, and the monitoring of cerebral perfusion pressure. It is important to monitor these two tools to decide where to make surgery for patient. The surgical management could be decompressive craniotomy for contusion or evacuation for collected hematoma. For our team, decompressive craniotomy for brain contusion, at which moment we have to grab the opportunity window. What is the opportunity window? It's the start of refractory of high intracranial pressure and the start of refractory of decreased CPP. We have to grab this window to anticipate, to gather elements for the collegial decision with anesthesists and all neurosurgeons. this timing is crucial. This timing have to be done after the G1. Because before the G1, we have the mechanism of cellular and vascular and hematoencephalic barrier disorders. That is before the G1, the surgery can precipitate this evolution, and the surgery can destroy the brain parenchyma. So the consensus is to organize the surgery after G1. For example, here it's emergency surgery because it's a light admission. The surgery, the goal of the surgery is not to manage this contusion. The goal of the surgery is to make the decompression. Here too, the goal of the surgery is not to remove the contusion, is to make decompressive craniotomy. It's the same indication for this CT scan for this patient. We can also use the Manzanera score. This score can help to early indication. When the score is below or equal to 4 points, it's indication that it's predictive that the secondary lesion will increase. So it can help to use this score to decide where is the best moment to make the craniotomy. For this collected hematoma, there is no doubt it's indication of evacuation of hematoma, and in some case, craniotomy associated with evacuation of hematoma. This collected hematoma, it's an indication of evacuation of hematoma and also decompressive craniotomy. For this example, we advise to make lobectomy and decompressive craniotomy because we are in the right side, and it's not possible to stop the evolution of this contusion to hematoma with only decompressive craniotomy. And for this patient, collected hematoma, and also here collected hematoma, it's an indication for evacuation of a hematoma. In conclusion, I said that it's a lecture for residents. They have to know that they have to fix knowledge of the mechanism of secondary lesion because this knowledge give us to standardize the management of contusions. Thank you very much.
Thank you.
Thank you, Professor Samuela.
Thank you, Professor Samuela. Go ahead, my friend.
Okay, just a comment. I saw the last CT scans. He said that there are indications for surgery. I think we must put in mind that we must make connection between the clinical data and the radiological data. Most of these people, if you follow them with not with CT scan every 6 hours, you can find some of them will not need a surgery. But we must put in the indication, the midline shift, the amount of the hematoma, the site of the hematoma, many things really. Many of these people really, they can escape from surgery and they can remain fine. People somewhere in different countries are using some like tranexamic acids and some things to make that this evolution stop by intravenous administration of some drugs. Therefore, if we can avoid surgery, but the patient under our strict monitoring, it's better, I think.
Yes, you are. Yes, you are right. When the anesthetist can stop the increasing of the ICP and can give good cerebral pressure perfusion, it's not, we don't have the indication for surgery. The surgery is indicated when we have refractory ICP and we can stop the decrease of cerebral perfusion pressure.
I don't know if Professor Tariq is here. Just I want to underline the effect that mannitol is used wrongly in many of these contusions, because the mannitol is working on the healthy tissue, and it reduces the brain healthy tissue and will increase these contusions. Therefore, many people are using still mannitol to reduce the ICP, but really in these cases, mannitol will be wrong and will make worse the patient. I don't know if you agree with this idea.
Mannitol, for me, mannitol is used for the vasogenic edema, only for the vasogenic edema. It can't be helped for the cytotoxic edema.
Dr. Imad?
Yes.
Yeah.
Yes, you can, Professor Abdessalam.
Thank you. Thank you very much, Professor Sanosi. It's an excellent presentation. You said that you thought that your presentation will be for a resident. This is the reason you did it very well, because I think that the most important presentation and the most difficult is to make the resident understand and to give them the basis. At the same time, the basis, the rules, and also some high-level aspect of the subject. And I think you did, and you exceeded. Thank you very much for this presentation. Of course, your division of the prognosis of these patients on primary and secondary lesions are very, very important. And as you mentioned, neurosurgeon is a part of the management in both steps, either in primary and in secondary lesions. The problem is we need many also other colleagues, either in the first step and in the second step. And we are suffering today, I think, in African countries more than other places from this, the lack of the team. And it's difficult to say if our head trauma patients lost more from the primary or secondary lesions. If I can ask you, for example, in your experience in Niger, are the first step of the transportation of the emergency taking care as the beginning are the most important problem for you today, or maybe more the secondary step, the secondary lesions, with the long stay in the intensive care unit, with the need of high professionals, either as doctors in the intensive care or also as nurses, and then the physicist and so on, which makes you maybe today suffering more with your patients. This first part of the management or the second part of the management?
Yes, you are right. You are right, Professor Hamilishi. You are very right. Thank you. Thank you for your comments. It's real that in my country, um, from the beginning of my experience, it was not possible to see patient at the moment of primary lesions. Many of patients are seen at the state of secondary lesions. But now we have CT scan, many CT scan in Niamey, so we can see patient at the primary lesions, and we are organizing ourselves to reduce the risk for transformation to the secondary lesions. Oh. And we are organizing ourselves to take this window of opportunity to make the surgery at the best time in consultation with our anesthetist. And unfortunately, in some case, despite of this organization, we have some patients staying a long time at intensive care unit. And they died finally. And we are asking ourselves if it was a good decision to make all this of this management. So the problem is real to ask ourselves if sometimes it's normal to continue to operate, to make decompressive craniotomy for patients under Glasgow, under 6 Glasgow. Yeah. I think it's not, in my country, it's not ethic to make surgery, decompressive craniotomy for patient under Glasgow 6.
Thank you.
Can I have a question, please?
Please, just to congratulate also Professor Samuela for this really excellent presentation, because it's very didactic. You give to the young neurosurgeon the definition of between contusion, attrition, and hematoma. It's sometimes not easy, even if we are senior, to give the right words on the right lesion. This is my comment. Secondly, I would like to know, in your daily practice, you use the Doppler, transcranial Doppler, for when there is expectant the secondary lesions. This is the first question. And second question, do you use also the monitoring of the pressure, the intracranial pressure?
Pressure.
And sometimes when we in our practice also we don't use it because we are scared and scared about infection. Especially in this patient, this monitoring can take many days, and the risk of infection will be higher when you have. Of course, when you go over 1 week or 2 weeks, and it's take sometimes more than 2 weeks. And in this sometimes in this situation, when the cranial intracranial pressure still higher, even if you use, of course, all the drugs, all the things that our ICU professional use. We use mannitol, even if it's not vasogenic, because there is also vasogenic, and there is the two things in physiopathology of this brain trauma. And my last question. The compression, the the decompression is still controversies till now. You use one of the classification, but one of the best for the indication of the decompression, brain decompression is still now the monitoring. When you monitor your patient, and even if the depression is still higher, you can at this time use sometimes when you have, of course, when the indication in all regarding the coma Glasgow scale, regarding also the peak, the pressure intracranial pressure is still higher. This is in this indication we can use decompression, but decompression still till now there's no it's controversies, no consensus in this indication. What do you think about that?
Exactly, you are right. You are right, because the compressive craniotomy have not give the expected results. That is why it's controversial question. Your first question is about the monitoring of ICP in Niamey. We don't have the system to monitor the ICP in Niamey. We use two things. The first thing is the cerebral blood perfusion. The second thing is capnography. When the capnography is the level of CO2 is high for our patient, it's an indication of a new CT scan. We suspected that the primary lesion is going to transformation to secondary lesion. If you have a contusion and a higher level of PCO2 and hypoxia, and the decrease of cerebral blood pressure, it's for us the indication of a new CT scan. And when the new CT scan show us sign of ICP or collection of hematoma, for us it's indication for decompressive craniotomy alone. If the hematoma, if the attrition is not collected, we done only decompressive craniotomy. If the hematoma is collected, we done decompressive craniotomy with evacuation of the hematoma, only the evacuation of hematoma. That is why we do this surgery after G1. If you try to do this,
las palabras que dejó el maestro de investigar.
At the first day, we have the risk of transformation of the contusion to a large hematoma, and the patient have the risk to going bad, to go bad.
Thank you.
Please, Madam Ebedi?
It's okay. Thank you.
Can I add some information about the Samuel lectures?
Mm-hmm.
So, thank you for Sir Samuel. I have some information to add about characteristic of the ballistic trauma. So, in this specific case, the brain lesion depend on multifactorial factors. The first one is the speed of the projectile. So, we are know well about some scientific data. It's the difference in the brain lesion without high speed projectile and with low speed projectile. The second comment is about the blast injury. So, and the third component about this ballistic trauma is infection risk. And the fourth point, it's about the ricochet phenomena and secondary projectile of bone, secondary to the first projectile. So this some information must be added to this ballistic trauma for the basic information. Thank you. Was more can go on. Thank you very much.
Thank you. So, Dr. Talahma, is there any question,
No.
or shall we move to the?
We can go to the
Fad,
lecture.
can I?
Yes, please. Yes, please, Professor Azhari. Yes, please.
Thank you. I will congratulate our friend Professor Sanosi. It's really very interesting to make reminder us all you did, and you did it very well. Thank you very much, because we have to sometimes we have to demonstrate or to show to our anesthetists that we know also the physiopathology of trauma, and sometimes we can go together for the decision. What we have in last months is we have four patients. For 2 patients, our anesthetist make a pressure on us to make decompressive operation. We did it, and there is no very good result. But 2 patients after, the same pressure, I'm not very convinced to do that. One, it was the compression of posterior fossa, for not for trauma, but for hematoma, hematoma. And the patient wake up. And I was very surprised, because he was in very poor condition. It's sure that it's not the same, posterior fossa is not the same as the subtentorial. And time to time, we have some surprise, but we are not, there is no argument. There is, as the Professor Abadi said, there is no real and scientific argument and to convince us to do the compression flap. And we do use the pressure. And sometimes I think it's interesting to make external shunt for when there is for ventricular hemorrhage, and to measure the pressure. If the pressure is going up, we can open the shunt, but also it's not very sure as a procedure and as a technique. I think we have a lot to learn about physiopathology, and it depends of every patient hasn't the same physiopathology as other, so it depends. So we have not always the same result, and sometimes it works and sometimes it's not. But congratulations, Professor Sanosi. We know that you did very big job in Niger, and thank you again.
Sorry, Samad, Professor Samuel, I was disconnected because they have a problem with the internet.
Okay.
But I record your.
He's connected.
Yes,
he's connected now.
I record your comment, and I will send him if he is here. If I don't think it's if he heard something.
He is back. He is back. I don't know.
Yeah, but
just,
I'm not sure that he heard the
my comment.
No, but I'm
back. But I
record it. I will send it to you by WhatsApp.
Yeah, exactly.
Congratulations again, Professor Sanosi. It was very nice presentation. Thank you again.
Thank you. Thank you very much.
Thank you, Professor Sanosi, for your talk and for your participation. And let me say, for your generosity to share with us, to be with us on every event in Africa. So our next speaker is Professor Abenezar Tirsit from Addis Ababa, and it is my pleasure to ask the Secretary of the Moroccan Society of Neurosurgery, Dr. Mouna Bougrine, to introduce Professor Tirsit. Thank you.
Thank you, Dr. Derkawi. It's my pleasure to introduce Professor Ebenezer Tirsit, who is assistant professor in the Department of Neurosurgery in Addis Ababa University, and also the director of Clinical Governance and Quality Control Directorate of the College of Health Science in the same university. He is also a founding member and the current president of the Society of Ethiopian Neurological Surgery Professionals, and he is a member of continental and international neurosurgical societies. And once again, on behalf of the Moroccan Society of Neurosurgery, I want to welcome you to this Morocco webinar series 2020. So please go ahead.
Thank you very much. I would like to thank the Moroccan Neurosurgical Society and Prof. El Albadi and Dr. Fouad for inviting me to the Moroccan webinar series, and I will be talking about the ultrasound measurement of optic nerve sheath diameter, especially in resource limited setup as a means to, as a non-invasive and indirect means to measure the intracranial pressure. So to say something about where I am from in Ethiopia. So neurosurgery is quite a young profession in Ethiopia, and before 2006, there were only 3 neurosurgeons serving the entire country. And the neurosurgery training program in Addis Ababa University was first established in 2006. And currently we have 44 practicing neurosurgeons graduating from this program and 73 residents in 3 different training program in Ethiopia. And from the number of surgeries we did over the last decade, almost 60 to 70% of the major surgeries was for trauma, and trauma is quite common in Ethiopia. And currently we have neurosurgical practices in 7 cities outside the capital Addis, but the practices are usually, there will be only 1 or 2 neurosurgeons giving basic neurosurgery and mainly neurotrauma services. So as a background, in most resource limited setups, invasive intracranial monitoring devices are not available, although these are the golden standards to follow the intracranial pressure. And in our setup also, we don't have any invasive means to measure the intracranial pressure. And we depend mainly on clinical and radiological evaluations of patients to indirectly estimate the intracranial pressure and follow patients. And bedside ultrasound can be used as a simple, fast, and indirect means to assess the intracranial pressures. And there are reports showing the use of MRI and CT scans as a means to assess the intracranial pressure, and this either CT or MRI can be used to for optic nerve sheath diameter measurement, and the discrepancy in measurement between CT and MRI is not significant according to a report from New York. And but CT and MRI are not always available in most resource limited setups, especially if you are working outside in our country, especially if you are working outside the tertiary hospitals. You may not have in-house scans, so you have to send patients outside the hospital to get a CT or MRI. And sometimes even in the hospitals, for patients in the ICU, intubated patient on mechanical ventilators, it could be very difficult to transport the patients and do serial CT scans for patient follow-up. So the role of ultrasound can be very valuable in such kind of setups. So there are reports from the American College of Emergency Physicians showing how sensitive the ultrasound can be in detecting raised intracranial pressures by measuring the optic nerve sheath diameters. And this was correlated with the intracranial pressure measurement and also with the CT scan or MRI findings, and the sensitivity was quite high for ultrasound. So coming to the basic embryology, the optic nerve is derived from as an output from the diencephalon of the brain, and when the optic nerve migrates into the orbit, it inches all the three layers of the meninge, the dura, the arachnoid, and the pia maters, and this forms the optic sheath. So the subarachnoid space within the optic sheath is usually in direct communication with the subarachnoid space in the intracranial pressure. So pressure within the intracranial spaces can be transmitted into the optic sheath, and so for this reason, when there is a pressure change, the change can be detected as a change in the size of the sheath, the optic nerve sheath. So usually the standard is to 3 millimeter behind the sclera is the site to measure the optic nerve sheath diameter, and this is a bulbar segment of the optic sheath, and it's the optic nerve, and it's believed that this is most sensitive to show the change in the intracranial pressures. So regarding the learning curve, interestingly, there had been reports regarding the learning curve. So they compared the board-certified optic nerve sheath diameter measurement from a CT scan by a board-certified radiologist with an ultrasound done at the emergency department by emergency physician who had a short course training to do the ultrasound examinations. And the conclusion from this study was the emergency physician were able to accurately measure the optic nerve sheath diameter with a bedside ultrasound after brief training sessions. So this showed that it can be easily trained, and all physicians can use this technique. So our experience, this technique was introduced into our hospital first in 2014 to the emergency department. So subsequently the emergency teams trained the neurosurgery teams to do the basic techniques, and so training of non-radiologists, especially surgeons and emergency physicians to do the ultrasound had been a more visible way of using this ultrasound technique in our setups. So far in our department, 14 residents and faculties from neurosurgery and 16 residents and faculties from emergency medicine did the training. So the training consists, you have to do the ultrasound examination on a simulator at least 10 times, and the residents has to do the scan on each other at least 5 times, and after that they will be able to do on the examination on patients. And usually the learning curve is after you did your 10 proper ultrasound measurements, so you will have a good capacity to use this technique. And this optic nerve sheath diameter measurement using ultrasound can be used as a valuable means also to follow patients. So there was a report which showed in patients with idiopathic intracranial hypertension who presented with severe symptoms to the emergency department, and when the ultrasound measurement of the optic nerve sheath measurement was done initially, it was 7 millimeters, and the emergency physicians did LP, and the opening pressure was around 30 millimeters of mercury, and they removed 15 cc of CSF, and the patient symptoms improved and discharged home. And after the second and the third post-LP days, the patient came back to the emergency complaining severe headache. So they used the ultrasound techniques to they used the ultrasound measurement to rule out whether this is a recurrent intracranial hypertension or just it's a post-LP headache. And when they did the follow-up ultrasound measurement, they found optic nerve sheath diameter was 4.1 millimeters. So this was not significant. So they decided to follow the patient conservatively with analgesic, and the patient did well. So this is a good experience showing how we can use this technique to follow patients. And this is a patient from our hospital emergency department. This is a child, a 15-year-old child who presented to the emergency department with acute blurring of visions, headache, and vomiting, with a posterior fossa tumor, probably medulloblastoma, with acute hydrocephalus, and the definitive surgery couldn't be done immediately for setup related issues. So we decided to shunt the child, and at the emergency department before the surgery, the optic nerve sheath diameter was 10 millimeter, and after the shunting and the patient is awake from the general anesthesia, she had significant improvement in her symptoms. And when we did the repeat scan, the optic nerve sheath diameter changed from 10 to 6 millimeter after 16 hours of inserting the VP shunt. So this is one example how we can, how we used it to follow patient. This is another patient who presented to our hospital with left CPA tumor, probably schwannoma, with obstructive hydrocephalus. So when we did the optic nerve sheath diameter, she had almost 6 millimeter optic nerve sheath diameter, and when we did fundoscopy, she had a blurred disc. So all this can be correlated and it can be useful. So adding the fundoscopy can also be useful to further assess patient's intracranial pressure. So when we come to the technique, usually patient will be positioned in a supine position, and the measurement will be done with closed eyes, covering each eyes usually with tegaderm, and we use gels, and both eyes has to be examined, and each eyes has to be examined in perpendicular planes, and you take an average of 3 measurements to have an accurate measurement. So this is a transverse section scans, and you need to do another scan in perpendicular directions, and usually the measurement which we take is 3 millimeter behind the sclera. This is a bulbar part of the nerve, and this is very important. So when we did the examination, the most important part of this ocular ultrasound anatomy is you have to have the lens together with the nerve, and you do the measurement parallel to the optic nerve, the sheath measurement. So when you do the optic nerve sheath measurement, it has to be parallel to the optic nerve. And the criteria to say that we have an adequate scan is you have to do the measurement 3 millimeter behind the sclera, and the measurement has to be done in a parallel direction with the optic nerve, and the lens has to be visible. And the other thing is the lens has to be dome shaped. If it's flat, it means that you have applied excessive pressure in the eyeball, and this gives you inaccurate measurements. So the normal optic nerve sheath diameter measurement is for adult patient is usually 5 millimeter, and anything above 6 millimeter is considered abnormal, and 5 to 6 millimeter need clinical correlation. But for pediatrics patient, it could be tricky, especially for children with open fontanelle. So this is one of the challenges to use this technique for children with hydrocephalus. So serial examination is usually very important. So in our hospital, we tried to use this technique for assessing TBI patient at the emergency department last year, and we scanned 87 patients, and the median age was 24 years, and most patients were male. So 24% of the patients had severe TBI, and 40%, almost 40% had mild TBI, and almost all patients with severe TBI patients had optic nerve sheath diameter measurement more than 5 millimeter. And from the 35 patients with mild TBIs, almost 32 patients had optic nerve sheath diameter measurement below below 5 millimeter, and we tried to correlate the CT scan finding of this patient with with the optic nerve sheath diameter measurement, and 11 out of 21 severe TBI patients had midline shift more than 5 millimeters on their CT scan. So the CT scan finding and the ultrasound measurement of optic nerve sheath diameter findings can be correlated. And most of our patients present late to the hospitals. And for as a follow-up, we did a repeat scan in this group of patients 1 day after the initial examination, and 5 of the 21 severe TBI patients had improvement in their GCS, and these 5 patients almost all had some improvement in their optic nerve sheath diameter, and this was a measurement which was taken after medically treating the patient for raised intracranial pressure. And as a conclusion, ultrasound measurement of optic nerve sheath diameter can be used to detect raised intracranial pressures and follow patients with raised intracranial pressure and augment clinical decision making, especially in resource limited setups. And thank you very much.
Thank you very much, Professor Tirsit, for this great talk. Maybe my friend Dr. Ahmed
really
have a question.
Yes.
Or comments.
Did the training on doing this ultrasound is easy. We can make training via internet, because it is excellent. It can help us so much in the outpatient clinic, also for the normotensive hydrocephalus or for the pseudotumor cerebri, because I have many cases in my clinic, pseudotumor cerebri, and sometime after making LP, you don't want to repeat MRI, and it is really a very good tool. Thank you very much. I will take your contact, and if you can teach me how to do it, I will begin using this tool.
Thank you.
Afed, Muna, may have to.
Yes, Professor.
Thank you, Professor Anazir, for this amazing talk, because you introduce us this tool, and we know it's very relevant when, of course, in some countries when we cannot, when the CT scan not available to every time. And my question is, do you have some experience and comparison between this ultrasound measurement of optic nerve and ultrasound ultrasound for transcranial along the middle artery, to of course to measurement the not the measurement the
transcranial Doppler.
Yeah.
The transcranial, the peak, the
evolution of the pressure in the middle artery cerebral, yes.
In the evolution of the patient with the intracranial pressure is raised or not.
Yeah, thank you. In our setup, we don't use transcranial Doppler ultrasound measurement. We don't use it, so we don't have any experience of comparing the optic nerve sheath diameter measurement with transcranial Doppler. But maybe in a setup where you are using both, it could be an interesting to see and correlate. But there are reports correlating CT or MRI measurement with optic nerve sheath diameter measurement, and it's a good, the ultrasound measurement can be used as a good sensitive tool to detect the raised intracranial pressure, but the specificity is a bit low.
Yeah, because we have a little experience with the transcranial ultrasound along the middle artery, and sometimes our physician of ICU said us there is some problem because we have some problem with the ultrasound. They did it every morning, and when we did the CT scan, there is a correlation every time. There is a correlation between the raise in not raising, increasing the flow of the blood in this artery with the CT scan when we do it after that.
Mm.
So I'm sure that it's same for the ultrasound measurement of optical nerves.
Yeah.
Yes, Professor Al-Khamnishi.
Yeah, thank you very much, Professor Abenazir Tirsit, for your talk on this very, very important subject. I would like to make two comments. The first one, to thank you for this collaboration between Ethiopian neurosurgery and Moroccan neurosurgery and your presence in this webinar. And I would like to tell you a quick story which will show you that this collaboration go back to more than 30 years. In 1994, I visited Addis Ababa to attend the 40th 40th Congress of the PANS, which was organized at that time by a colleague neurologist. There had been very few neurosurgeons. And the neurologist who organized the Congress was Professor Haymanot. I don't know if you knew him. Maybe he's one of your masters. You know, the oldest neurologists were masters of neurosurgeons in many countries in Africa, like in my country also. And at that time, I was seeking the support of PANS for the Marrakesh World Congress candidature. And I remember the support of Dr. Haymanot and also the PANS at that time. So it makes me very happy to see today that the Ethiopian neurosurgery is engaged in this support of African neurosurgery and of course of Moroccan neurosurgery. So thank you very much for being in this webinar. And the second comment I would like to make is regarding your original and a very important technique to measure the intracranial pressure. I was involved in the measurement of intracranial pressure since the beginning almost of my specialty, because after having finished my residency in the 70s, I went to Switzerland for some years. And the research topic they have given me at that time was the development of telemetric technique, which is very difficult to measure the intracranial pressure. And then when I came back, I was very interested in the benign intracranial pressure, and we prepared a report on that to the French-speaking Society of Neurosurgery when they had their meeting in Marrakesh in 1984 or 83, no, 83, in 1983. I see here Professor El-Warzazi, who was the president of this Congress at that time. And since that time, I have gotten a lot of patients with benign intracranial pressure. And it's very difficult to repeat the control and the measurement of the intracranial pressure, either by lumbar puncture or by a monitoring technique. And it's the same also in the case of head injury. So I found that your technique is very important, and I would like to ask you and to push you to teach it in many countries in Africa, because for someone who is mastering the ultrasound technique, it's very useful. Especially that ultrasound also is used in many other neurosurgical needs. So really, I'm so happy to hear your lecture and to see you interested in this technique and developing it, of course, in Addis Ababa, and certainly I hope in many other African countries. Thank you.
Thank you very much, Professor Kamilici, and it will be a pleasure to see you again in Addis. And this technique was introduced to our hospital 6 years back by colleagues, emergency physicians from New York Metropolitan Hospital, and we use a butterfly IQ ultrasound. This is a portable ultrasound. Which have just a probe, which I tried to show the photo earlier, and you can attach it with an iPhone. So if you have the software in your phone, so you can just use it, and this is very simple and portable way of measuring, and it had been helpful for us so far.
Excellent, thank you.
Thank you. Go ahead, Dr. Bougrin.
Is there any other question in the? No.
There is a comment in the chat.
Yeah.
I think there is a question of
if any no questions
of Professor Abdel Hakim Al-Khadar. He asks about pathophysiology and mechanism of evolution of the initialization after TBI is fundamental for adequate management of the anticoronary lesion. It was a comment. And Professor Mustarshid has a question, I think, or comment.
Thank you for all the speakers. I want these questions about, I want to know your opinion about national and international speakers. What's your opinion about the large decompression craniectomy? They can be made first, followed by the basal cisterna opening. Recently, we did it in some people who at the end of the large decompression craniotomy, we make cisterna opening with microscope or without microscope. It seems for us to give more CSF removal, and my feeling, it's not a statistical scientific data, that it gave more opportunity for the prognostic. What's your opinion? I make a question about the national and international speakers. Thank you.
Yes,
clear? What your opinion about the cistern opening, basal cistern opening?
We have a good discussion for this in Ikran in Nablus, and really some people they think that is fundamental to go there and to open the cisterna, but there's no consensus for that. Most of the people are speaking about how wide is the opening of the cranium, and it is important not to cause further increase of the edema because of the wedging of the veins. Therefore, it is very good to decompress the brain and to put in the mind not to have any pressure up to the cortical veins. Really, because the most important thing is to make good outflow of the blood from the brain. The movement of the blood in and out must be good, and this will help reducing the edema and the intracranial pressure, and this will make the perforation pressure better. Therefore, the question is not how space you give, because if you want to open the cistern, you must you need to give more space for the brain, yes, but and this is because you open the arachnoid more farther. But if you decompress the dura and you add to the dura some fascia or some artificial dura, you can in this way give better blood perfusion to the brain. and this will help. This is the idea was in Naples, in ICRAN, in the meeting, international meeting in Naples, Italy, and just a few people were feeling that it's good to open the cistern at that time. I don't know if there's a new studies. This was 3 years back, I think.
If does someone have any comment about this?
I don't have experience on it. The problem for me is how to reach the basal system.
Absolutely.
Because you have edema, and I don't know how to reach safely the basal system. I don't know. I don't have experience. Thank you.
Thank you.
I agree with you, because we know that there is a lot of edema really to
of course.
Reach the basal cistern is not easy. It can induce more damage to reach this area than ever, because all the brain is with the edema. So I think it's not easy. I don't have any experience also about it. Professor Tariq Khan, maybe you have some experience about his.
He has reported in his lectures this approach. Professor Khan, are you here?
If Professor Khan is had to leave us for another appointment, he's sorry that he should leave us. But about this technique, if you allow me, I think there is paper published by Dr. Sherian, is from Nepal, about what can some microsurgery tricks can add to manage brain trauma, and he insists on his paper that is for selected cases.
Yeah,
so
sure.
For selected cases, or not for all cases with decompressive chronectomy. He did this. He does. I remember he don't give more information how to select these cases, but I think I know many colleagues in Morocco that have done that, and they say that for these cases that it's improve the outcome. But I think that we need a prospective study and to evaluate the importance of these techniques, and how can we add it to our guidelines for management of traumatic brain injury.
It's difficult. The brain is swollen. I don't speak about the ultra macroscopic dissection between all the cisterna. I have just to open the arachnoid in basal arachnoid with the spatula. If you have microscope, you can remove some SSF. But I don't dissect the carotid, the I2, optic, and the other basal anatomy. I want just remove some SF by a spatula. I know the brain is swelling and it's not easy, but in some experience, my feeling is can help. It's not to just add a technique. We must to evaluate this. Yeah. Thank you.
That we couldn't have with us now right now Professor Tariq Khan, because he organized many meetings about TBI, and he is the co-chairman of the WF TBI. So maybe he had some answers. Professor Mustashid, not easy when you, as
yes, sure, it's not easy.
Swelling, when there is a swelling.
Najia?
Yes, yeah, you can. Yes, we are saying the same thing. I'm not. Yes, please, Professor Azhari.
Thank you for your question, Professor Martili. Professor Mustarshid. I think, as our friend Professor Ahmed said, it's the decompressive craniectomy has two goals. First goal is to permit to the veins to be more free for the back of the circulation, and the first goal is also to make a difference between artery circulation and back of venous. When there is edema and hyperpressure, it's the peak intracranial pressure is going is increasing and is going to equal the artery pressure, and that is the problem. That is the problem. The goal is to decrease the intracranial pressure in order to let the vascularization, the arterial vascularization for the brain to go more, and after that to make free venous. I haven't experienced about this technique, Professor Mustarshid, but when we perform the decompressive craniectomy, it's really very big edema, and all the veins bridging from
yes, you are true.
From up to down.
You are true.
It's very difficult. Is crossing all the temporal, and it's very difficult to go to the basal cisterns. But I have no experience about that. I think personally, I think it's not good to complicate the compressive craniectomy, and to let it as we do it is to make place for brain.
Yes, I think some people are using this to release the arachnoid when there's a big amount of post-traumatic subarachnoid hemorrhage. Post-traumatic subarachnoid hemorrhage. Some people feel that they must release more to avoid arterial stenosis, post blood collection around the arteries. They did it overall in the basic cistern, but it is not a usual procedure, and mostly because you are running to save the life of somebody.
Yes, in selective cases. It's not all the patients.
Okay.
So, any comments about this, Madam Abadi? You have some comment or some questions?
No,
or Azhari?
Nice.
Fahd?
Okay, I don't know.
Just
there's no more question.
Just I want to congratulate again Professor Tirsit. Next, I promise you after COVID, if there is some meeting in Addis Ababa, we have been there. So perhaps it should be a very opportunity to meet people from Ethiopia. And thank you for your participation.
Thank you very much. Looks forward to see you all in person.
Inshallah. Thank you so much.
Thank you.
Yeah, I think there is no questions in chat, no comments, no questions.
No more questions, no.
No more question. Okay, so I think it's the end of this webinar. We will thank again all the speakers for their excellent, really talks, different talks between political global neurosurgery with Professor Tariq Khan, didactic, and for resident, really, I greatly appreciate the talk from Professor Samuela for didactic presentation, and the last but not the least, our friend from Ethiopia for this really interesting tool to follow the intracranial pressure, and also the panelists for their participation, especially our friend from Palestine, Ahmed, of course, Professor Mustarshid and Dr. Muna Bougrine, for their participation to moderating this the webinar. The discussion was very interesting and passionate. And the last one, thanks Fed for your participation always for this webinar, for organizing it, and also participation in all the discussion, coordinating all the webinars, all the meetings. Thank you so much.
Professor Sanosi, you want to speak, I think.
Yes.
No, nothing. I want to say bye. Bye.
Okay.
Bye.
Say bye.
Bye.
Bye. Take care.
So many thanks to all.
Take care and stay safe.
Bye, all of you.
Bye. Thank you very much. Bye.
Bye.
Hi, everybody. Bye.
Hi, everybody. Good evening. It's night.
Bye.